Thanks and welcome back to this final part of our ACL non-operative management masterclass today. So I'm Adam and Brooke. We're both back to chat more about osteoarthritis and some of the long-term outcomes following an ACL injury. And this is a real passion of mine. I've done a lot of research in this space over the last few years, and so hopefully we can sort of shed some ideas about some of the things that we can start to think about in our rehab processes with the long term in mind, because we've talked about injury prevention, we've talked about the treatment, but I think what I'm really interested in this sort of space is for the rest of the patient's life, they have an increased risk of osteoarthritis, they have an increased risk of re-injury. I think that's really important for us to start considering as well. So we're going to go through a few things. So in terms of radiographic knee osteoarthritis and the long-term outcomes, we know that an ACL injured knee is a much higher risk of having osteoarthritis. And you can see here from the graph, if we compare to non-injured populations, obviously as we age, we get more osteoarthritis on X-ray, but clearly standing out are those young people who have an ACL or meniscal injury history, with about 50% of people who have radiographic signs of knee osteoarthritis. So it's clearly something that is a problem for these young people. So they're young people with old knees, and 4 to 5 times more likely to have OA if you have a history of an ACL injury. So something we really need to start considering and thinking about. But I know both Brooke and I are really interested in not just the radiographic outcomes, but also the symptomatic and outcomes that affect patients. So thinking about quality of life outcomes. And this is a review from Steph Filbay during her PhD showing that compared to uninjured controls, we know that if you have an ACL injury, then particularly your quality of life compared to symptoms and pain and function, they're all a little bit reduced, but particularly quality of life. And you can see here on the graph very nicely that much lower than uninjured controls. And so we really have to start thinking about how we can try getting this quality of life in these patients back up to a level that uninjured controls are at. And this is more than 5 years after an ACL reconstruction, which you would expect them to be sort of back bang at their best 5 years down the track. So that's something we need to start considering as well.
Why do you think, Adam, it's the quality of life in particular
Yeah, it's a great question. I think quality of life questions on the KOOS outcome scale. Think about, are you aware of your knee during day-to-day tasks? Are you confident in your knee? And do you have any difficulties in everyday tasks? So I think those types of things, even in the long term, and even if you have maybe modified your activity because of your knee, can still come up and be highlighted in that quality of life subscale. And also, as we talked about earlier, a lot of other contextual factors that the knee injury might play into. So, work, family, occupation, ability to be physically active in a whole range of things. So I think that's probably the reason why. Does rehab-only treatment, so not having an ACL reconstruction, increase the rates of osteoarthritis? And that's a question really important that Mick and I talked about a little bit earlier in today's masterclass. And in over 30,000, data from over 30,000 cruciate ligament ruptures clearly shows that in the long term, so even up to 25 years following an ACL injury, there's very little difference in the rates of osteoarthritis we see on X-ray if you have an ACL reconstruction or if you don't have the surgery. So some of the things that might be sort of contributing to that, which we sort of touched on a little bit earlier, is really that secondary trauma of the ACL reconstruction itself, prolonging all those inflammatory cytokines, which can often have an influence on cartilage, softening the cartilage, unable to withstand the load that we sometimes put these patients through, are some of the hypotheses about why a reconstruction may not be preventative for osteoarthritis as well. So we talked about some of the meniscal tears contributing to that rate of osteoarthritis earlier in the masterclass as well. And I think it's really important to realise that meniscal tears are an important risk factor for osteoarthritis, and that an ACL reconstruction may reduce those rates of meniscal tears, but not in everyone. And I think observational studies have shown that the longer we wait and delay the reconstruction, the more likely there is to be a meniscal tear. But of course, people who have a delayed surgery are more likely to have that surgery because they have problems. and have symptoms and they need to go and have that surgery. So that we need to be really careful in interpreting that type of data. And when we look to randomized controlled trials, such as the Canoon trial Mick talked about really well earlier, we see actually no differences in the rates of surgery or meniscal surgery in the different treatments. And as we mentioned, it's having the instability episodes that really dictate the importance of meniscal tears. So unstable knee, you're more likely to be giving way and more likely to have a meniscal tear, and that's what we want to try and avoid. In terms of whether quality of life outcomes differ between ACL injury and reconstruction, again, Steph Filbay published this really nice systematic review showing very little difference combining all of the different studies that look at quality of life outcome compared to surgery and non-operative management more than 5 years after ACL injury, and showed that the combining all of that data, as you can see on the forest plot here, because that triangle down the bottom crosses the middle black line, there's no difference between the early reconstruction or the delayed or non-operative reconstruction, non-operative management as well. So we can be confident that the one treatment option is not more superior than the other, not only for OA, but also for quality of life. But a real passion of mine, and I know Brooke has done some work in this space as well, so we'll chat about this in depth now, is the early osteoarthritis outcomes for these patients. So as they're going through their rehab process within the first year, what can we sort of identify in these patients that might put them at risk of longer term OA? And we've shown that using MRI, so not X-ray, which only takes a number of years to develop into structural changes, osteophytes and joint space narrowing. But using MRI, we found that almost 50% or over 50% of people have already early signs of osteoarthritis on MRI, such as cartilage lesions, bone marrow lesions, osteophytes, and particularly meniscal lesions as well. And so if we combine these, so this is a study of 111 people, mean age of about 26, previously involved in sports activity most of the time, so a typical ACL population. At 1 year, we can say from our MRI findings that about a third or 31% of people already have MRI-defined osteoarthritis at 1 year after reconstruction. So that's things such as an osteophyte combined with a full thickness cartilage loss, or a number of other factors such as bone marrow lesions or meniscal degeneration. And what's really interesting is that we find higher rates in the patellofemoral joint compared to the tibiofemoral joint, which is something that, as Mick and I talked about, we've also found in the Canoon trial. And this is some of your work, Brooke, that we get you to speak to, but also not only is it highly prevalent at 1 year, but in our 5-year follow-up data, so we followed these people for another 4 years, so they were 5 years after ACL reconstruction, they continued to worsen. And so, Brooke, maybe if you sort of briefly touch on...
You can see here that in the patellofemoral joint there was 44%, so almost half of the patients had worsening, so either like new lesions or more like severe lesions in that 4-year period, compared to only like 11 and 13% in the medial and lateral tibiofemoral joint, which people are always really interested in, because we know that this cohort are only hamstring autografts, so some people get a little bit like, okay, like I thought maybe only patellofemoral joint was affected when people have patellar tendon grafts. So why do we think why do we think that why is the patellofemoral joint affected?
It's a great question, and one we've had lots of discussions about, even with some of the surgeons, and often talking to them, they go in and on the people who have a secondary ACL reconstruction or a scope, telling us feedback that they seem always, the trochlear seems to be the joint cartilage that arthroscopically seems to worsen, and that's sort of consistent with what we're finding here. And why that's the case, we really don't have a good answer to that yet. I think it speaks to the fact that an ACL injury is more than just an ACL injury. The synovial fluid, the inflammation, obviously affects the patellofemoral joint cartilage as well. We know that some of the biomechanics changes occur that after ACL injury and don't get fully restored following a reconstruction can have an influence on the alignment of the patella within the trochlear groove, and so some of the more loading and cartilage contact may influence that as well. But I think that's something that we're both interested in finding out more about, and will come to evolve as we keep following these people up longer term as well. But I also think it's really important to recognise and highlight that a lot of asymptomatic or healthy people also have an MRI sign of early osteoarthritis, such as a cartilage lesion or a bone marrow lesion. And And this figure here is from our recent systematic review, where we only included people who were totally uninjured, asymptomatic, healthy knees. And from all of the different studies highlighted in blue here, which are the ones that have an age less than 40 years of age, and the lighter shade down the bottom for older people more than 40. We can see if we combine all of that data, that 11% of people under 40 who are uninjured and asymptomatic will have evidence of a cartilage tear on MRI. So that's something we really need to put into the framework of our imaging findings. And if we look at the older population, it goes up to 43%, so quite significant. So there's not a lot of strong relationship between what we see on MRI and what the patients are feeling, which we've known for some time. And I think it's important to put this into context of what we're finding after ACL. And interesting in your study that you mentioned, they actually continue to worsen. So it's not just an incidental finding, they actually, a large proportion of them continue to worsen over time.
Yeah.
So,
and do we know from other studies whether these people that have got this early OA on MRI, do they go on to be the ones with the more severe radiographic OA symptoms?
Yeah, great question. Yeah, so great question. So there's a little bit of data to show that if you have these early findings on MRI, such as a cartilage lesion or a bone marrow lesion, or cartilage lesion in particular, are likely to develop radiographic osteoarthritis longer term. We know that bone marrow lesions are a little bit more modifiable or changeable, if you like. So some can regress, some can progress. Some of the bone marrow lesions after ACL injury have different characteristics which are more likely to progress to worsening compared to those that different bone marrow lesions that are likely to regress and actually resolve just like a bruise under the skin. So we know that we can sort of identify people who are more at risk of longer term
and that's something
problems.
I've found interesting, comparing those worsening rates in, say, the different lesions, cartilage, bone marrow, compared to normal age-related change per annum, which, this group are obviously, as you say, at risk, and they're on this accelerated pathway. But I think, we've still got a long way to go to know which ones are going to end up in.
Yep, exactly. And it's like we talked about earlier, who benefits and who doesn't benefit from a reconstruction, who's going to get away, who doesn't, we don't have the answer yet, but we're just starting to put the jigsaw puzzle pieces together. So if we start to think about from a management perspective now, and how do we sort of think about preventing this osteoarthritis if we can? I know you talked about we can't prevent injuries, we can reduce their risk, so we probably should sort of speak to that language here as well. And some of Jackie Whitaker's work, and Eva Roos has done a lot of work on identifying or creating a context of people that are likely to be more at risk, and then identifying those and then managing and trying to modify those risk factors. So there's really a lot of different things that come into play here. Some of them are modifiable, some of them aren't, which we'll just go through and touch on briefly in the different things. So the first one, not surprisingly, being overweight or obese. We know that's a huge risk factor for developing OA in older people who don't have an ACL injury. We don't have a lot of data to suggest that this is also the case for an ACL injured population, but I think it makes sense that it is. If you have an ACL injury, plus if you're overweight, you're overloading the joint, etc., you're more likely to get away probably. So we know that in older people, if you, for every 10% loss of weight that you can achieve, if you're overweight, then this corresponds to an improvement of 50% in your symptoms and pain. So clearly very strong evidence to maintain a healthy weight or try and lose weight if you're overweight.
And do you think we, as physios, should be having that conversation? If so, when, or referring on? Or?
Yep, great question. So I think it's an initial conversation piece. I think some physios are more confident at having that discussion with others. I don't think we're experts in weight control, and different people feel different levels of comfort discussing with patients. So I think it's important to raise initially and have that discussion, and if there's more need to go and seek the right advice from professionals, dietitians, nutrition, and also remember that being physically active as well will help reduce weight likely as well. So that's something that I think we can really encourage. So the second thing to think about is muscle strength. We have a real importance of, as physios, is developing and maximising muscle strength during our rehab early on. And again, looking at the data from a systematic review, so combining all of the data together, we can see that having weak quads muscles in particular puts the knee at risk of the development for radiographic knee osteoarthritis. So this is typically in older populations who don't have an ACL injury. The data, if we pull out the studies that only look at an ACL injury, we know that they're actually a little bit more conflicted. But I think the message is there from all we've talked about today with the importance of rehab, progressing the joint, optimising the function, that strength is just good to get. Good, makes sense. Good to get strong in this context. It's not going to hurt the joint anyway. Function, again, talking about HOP tests and incorporating the strength into more functional outcomes. And we have data, pretty important data, to show that HOP tests, so limb symmetry index during HOP tests of if you're not achieving 90% function, we know that's a risk factor for re-injury, but we also have some data now to show that it's actually a risk factor for developing OA, which as physios I think is really empowering. We can, during our rehab be telling our patients, if you don't achieve at least 90% compared to your other side,
these are the risks.
These are the risks, and you're at risk, and we need to improve. So maybe a good thing for adherence and motivation. And the one-leg rise is one of my favourite tests, and I know Mick talks and loves this test as well. We've found that a number of reps less than 22 at 1 year after reconstruction can predict the symptomatic outcomes and quality of life a couple of years down the track. And the cutoff of 22 was taken from a study looking at older people with OA, so that's not the hard and fast rule. I think it just, again, starts a conversation to say, well, look, you're only getting 5 or 6. Clearly this is below what we'd be expecting at 1 year post-op, and as a surrogate measure for quadriceps strength, we probably should be working hard to get that.
Yeah, I think it's a nice one that you can use the whole way through,
exactly.
Because you can modify it if they can't get low.
The height.
Yeah.
And a really good exercise as well. If they're not doing well on this, you can actually use it as an exercise, make it achievable by increasing the height.
Yeah. It makes them work hard.
Makes them work hard.
You did it and then were sore for days, weren't you?
Dom's terrible. Elite athlete. And then something else I just wanted to bring up is the thought of overloading the joint, or underloading the joint. Perhaps how much load are we putting through the joint following ACL injury, and do we rest these people? We know that in older populations, the knee adduction moment, or the CAM, has been associated with increased rates and progression of osteoarthritis. Data, interestingly, following ACL injury, now recently coming out, shows that it may not be an overloading phenomenon in the young people following injury, but an underloading phenomenon, which I think is really, really interesting, and very early days in this space. But we have a little bit of data to show that the ACL reconstructed limb actually is underloaded compared to the non-injured healthy limb in things like running and HOP tests and things like that, and that is associated with early osteoarthritis that we've seen on MRI. And quite convincingly, actually, longitudinally, if you have a lower knee adduction moment, this is a study from the States in Delaware, at 6 months after reconstruction, if you have a lower knee adduction moment or lower CAM, that's actually a risk factor for the development of osteoarthritis radiographically 5 years later. So I think that's really starting to have a bit of a change in mindset from, overloading is really bad. Well, maybe actually in these young people following injury, it's the underloading that we're not stimulating the cartilage enough to create that turnover and natural health that we need in the cartilage and the synovial fluid. So I don't know whether you had any thoughts on this new...
Yeah, I definitely, personally from going through an ACL, I still underload that side. Every time I get up from a chair or something a little bit deeper, I'm just not even on that side.
Even
and
notice it yourself.
It's such a long rehab period for people just to have that mindset. They've got to try and be symmetrical in things that they're doing. So,
and some of these data show that they are walking symmetrically from a visual eye perspective, but when you actually do an in-depth look at their kinematics and kinetics, so the actual moments across the joint, that's when you see sort of sub-visualization level, if that's a word. Underloading, so it can be exactly
taking more through their calf or more through their hip.
Different movement patterns we need to be careful of. I think there's also a question around: is it around the safety of return to sport, and does that increase the risk of OA? Should we only getting these people, just back to walking and running, and let's not let them go back to sport because that increases the risk of OA, which a lot of people won't want to hear. And really, thankfully, there's some data coming out from Norway in their 15-year follow-up study showing that they looked at of people who returned to pivoting sports, so the basketballs and the soccer, football type sports. At any time during the 15 years, if you return to those types of sports, you actually had a reduced chance of developing osteoarthritis at 15 years. So that's really good, useful data for us, so we can encourage people to go back to sport, and that's not necessarily going to be bad for your knees.
And that was symptomatic and radiographic?
Both,
so
exactly.
Both,
60% or so reduction in the risk of osteoarthritis. And interestingly, when you look closer at this data, it's actually those people who returned to sport actually had better function. So they had better strength and better hop tests. And so it actually, bringing back to the earlier point we talked about, might be that it's the good strength and the good function that protects the people, irrespective of whether they go back to sport or not. And then the last couple of points, the psychosocial-contextual factors, which up to now we haven't really talked much about, and hasn't been a lot of data on this out there, to be honest. But things like kinesiophobia, fear of movement, confidence in your knee, they're not necessarily huge risk factors for the development of osteoarthritis per se, but I think they're really important to consider as potential mediators for a negative lifestyle that impacts on patients' quality of life and what they're doing, how they perceive their own self-worth in their sport, their locus of control, etc. So I think that's an area that's really going to start growing, and us as physios may not be the best people to fill this space, but I think it's, again, an important conversation starter to have if you're struggling mentally to adapt to the ACL injury and have a lot of fear. Then it's important we actually address that, not just the physical parts as well.
Yeah, and I definitely saw that with a lot of the people coming back at 5 years in our study. Yeah, they might have started to get a little bit of pain and were worried or were told things, and it's like, okay, well, I'm gonna stop everything. So we need to get to them and give them the right information, because if then they underload or they put on weight, and that's
all
a bad outcome for them. Yeah.
Exactly. And so I think it's more about then educating them really well, and initially and all through rehab, about one, the risk of OA, but also the importance of not only getting the physical impairments recovered and back to being optimal, but also the psychosocial stuff as well. And there's been some data that coming out of Melbourne and the USA actually looking at patients' beliefs and their understanding of whether ACL injury increases the risk of osteoarthritis. And really interestingly, of the 233 people who were involved in the study who were 1 to 5 years post-injury, 73% thought that their ACL injury increases your osteoarthritis risks. That's probably a good thing. Most people understand that they are at risk of OA. Quite interestingly, 2/3 or 65% thought that an ACL reconstruction actually reduced the risk of that osteoarthritis developing. So hopefully
we've cleared that up today.
Only about half of people understand what osteoarthritis is. So even though they know that it increases the risk, only half know what it is. So there's a gap there we need to fill to really educate and empower these patients about the need to address some of these impairments. And quite scarily and disappointingly perhaps, less than 30% discussed OA with their health professional during that rehab phase. So I think it's important to consider bringing into the conversation about this is not just a short-term injury to get you back to sport as quick as we can, but there's also long-term implications as well. And you're not necessarily going to get OA. Not everybody does develop OA and poor outcomes, but they're at increased risk, and the importance of being adherent and doing an optimal rehab process.
I think that's an important point, because physios might be maybe a little bit worried about alarming patients. So do you have any tips for physios about how to approach that conversation, when to not kind of scare them too much?
Exactly. So I think it's, again, really patient dependent and depends on your clinical case you have in front of you. So for example, some people who may have a lot of fear and lack of confidence, if you in the first couple of weeks of your rehab say, look, actually you're going to get OA as well and you're going to have a terrible outcome, then that's probably not quite the right scenario to build that into your rehab conversation. So I'd be a little bit more cautious around that and maybe build it in later on. On the other hand, if you have someone who's a little bit further in their rehab, maybe they're not adherent, they're not doing as well as they could and not doing their exercises, then starting to discuss some of this, the implications of that can actually be really useful to increase the adherence for them, and use that as a bit of a motivator for the patient to be achieving their best outcome, because that will, the preliminary data we've shown today, likely reduce the risk in those modifiable factors. So if we combine all of those sort of risk factors that we know of together, if you're going to start thinking about prevention of osteoarthritis after ACL injury rehab program, you're going to be looking at actively maintaining or reducing weight so they achieve a healthy weight. You're going to be strengthening your lower limb, quadriceps muscles in particular, but a global, closed kinetic chain movement patterns to optimize the function. Loading the joint adequately, I think, is really important. Facilitating and encouraging return to physical activity and indeed sport that the patients want to get back to, and managing the psychosocial aspects, the confidence and the fear within our sphere that we can. And I've just listed a couple of, or put a couple of really important papers that have been published very recently in the field, showing the importance of exercise and loading of the joint. To be honest, a prevention of osteoarthritis rehab program wouldn't differ a lot from a well-designed and well-executed initial ACL rehab program, strengthening, maintaining healthy weight, being physically active, return to function, etc. But I think it's important to have that in the back of our mind as we're rehabbing these folk. And I'd just like to finally finish off with just a really important editorial that was published a couple of years ago from the Norwegian group, highlighting the importance of implementing the current evidence in early rehab programs to improve and think about the long-term outcomes. And I really encourage anyone who's interested in more about in this space to go and review this paper. It really has a lot of insightful information, arguing that such an approach isn't currently used at the moment. We're not thinking about post-traumatic OA in our rehab, and that aggressive strengthening exercises, a strategy of optimal loading for the vulnerable joint to increase the dynamic stability, advise about the type and the level of sports activity to optimise the outcome as well. So anything else you wanted to add with that, Brooke?
No, I think, you've summarised it really well. I think it's, they're a challenging group, especially a lot of them are sporty.
Yep.
So as soon as they decide whether it's because of their knee or their lifestyle that they can't play sport, I think a lot of people struggle to go, well, what am I going to do now? And then they become very inactive.
Yep.
So I think
and it's a whole cascade.
I think you and Mick
together.
talked about it before, is like trying to be creative in how we can actually get them to still load their knee and be physically active.
Perfect.
Yeah.
So that brings our part of the masterclass to a close, and also brings all of the different components of the masterclass together to a close. So I'd just like to thank Randall Cooper and Mick Hughes for allowing Brooke and I to be involved in this masterclass, and thank them for their presentations today. And hopefully you've all got a lot out of all the different aspects, and we look forward to seeing you back again for more ACL education shortly.